Last time we were discussing about the disease of the adrenal medulla of the suprarenal gland, and the commonest pathology you will see in surgical practice is pheochromocytoma, which we have discussed in detail. Both the pheochromocytoma arising from the adrenal medulla, 90%, and 10% is extra-adrenal pheochromocytoma, which is also known as paraganglioma. Today we are going to discuss the disease of the adrenal cortex. The adrenal cortex is developed from mesoderm. It has no innervation. It has got three zones: the zona glomerulosa, then comes the zona fasciculata, and the innermost one is called zona reticulosa. Zona glomerulosa is mainly concerned with the production of a hormone. This is called aldosterone. Zona fasciculata is secreted a hormone. The principal hormone is cortisol, and the zona reticulosa produce the hormones is adrenal androgens, and sometimes really is the estrogen. First we will discuss how the different disease of the adrenal glands they present. First we will discuss the sex production of the aldosterone by the zona glomerulosa. This is called primary hyperaldosteronism. And increased level of the aldosterone is because of the autonomous production of the aldosterone by the zona glomerulosa. The commonest pathology is adenoma, which is only in 15% of the cases, and the 65% of the cases is bilateral adrenal hyperplasia, which may be micronodular or macronodular. The commonest presentation of the primary hyperaldosteronism, which is called Cone syndrome, or labeled as aldosteronoma, which is a microadenoma of the zona glomerulosa. It was thought that the essential hypertension constitute the 95% of the cases, and 5% of the cases is the secondary hypertension. You will be surprised to know in the current status, 10 to 12% of idiopathic or essential hypertension is not the essential hypertension, but the underlying cause is primary hyperaldosteronism. That is hypertension. These people, they present with hypertension plus hypokalemia. Or you will find the people, they have a difficulty to control the hypertension, especially the diastolic hypertension, by the physicians. If you find a patient who has got a hypertension, especially the diastolic, with hypokalemia, the diagnosis is usually labeled as this is a primary hyperaldosteronism or Cone syndrome, provided the patient is not taking any drugs like aldosterone antagonist or AC inhibitors. The clinical presentation, in addition to hypertension, there is also a weakness, muscular weakness. Sometimes you will find a severe periodic muscular paralysis, for which the patient has to go on ventilator. The diagnosis of primary hyperaldosteronism or Cone syndrome: 1. Clinical is hypertension. Serum electrolytes, the potassium is low. The normal potassium is 3.5 to 4.5. In these patients, you find the potassium is less than 3 or 2.5 or 2, severe hypokalemia. Once the clinical status is established, then answer is how to diagnose this case. The blood examination includes the aldosterone level, plasma aldosterone level, and the plasma renin activity, serum potassium as well. So if you find that the aldosterone level shoots up usually above 15 nanogram per deciliter, and the renin activity in this case is usually low. The ratio of the aldosterone level in the plasma to the renin activity in the plasma is more than 20, the diagnosis is established that you are dealing with the case of Cone syndrome or primary hyperaldosteronism. Once diagnosis is established, then what is the treatment of this patient? In treatment, the investigation to localize the tumor in the adrenal gland, especially in the cortex. That is, adenoma usually is very small in size, half a centimeter to 1.5 centimeter. That is why sometimes it's difficult to detect the small microadenoma of primary hyperaldosteronism. The investigation of choice is CT scan or MRI that can pick up the microadenoma responsible for primary hyperaldosteronism. And that is only in cases of 15% of the cases. 65% of cases there is a bilateral adrenal cortical hyperplasia, which may be micronodular or macronodular, difficult to differentiate between the adenoma and the unilateral adrenal hyperplasia. After localizing if it's adenoma, the answer is you should prepare the patient first. For preparation, number one, you should use the aldosterone receptors antagonist, that is spironolactone or aldactone. The initial dose is you can use 200 to 400 milligram per day, and then later on you can reduce to 100 to 150 milligram per day to control the blood pressure, because this is a diuretic, and that will reduce the extracellular volume. The intravascular volume will be reduced, and second is it will also increase the level of the potassium, because this aldactone is a potent diuretic regarding the antagonism of the aldosterone, and it will tend to raise the potassium level so that to prevent the cardiac arrhythmias during the operation. This drug is very effective, being used in Pakistan and also all over the world. The only problem with this aldactone or spironolactone, which is aldosterone receptor antagonist, is it is an anti-estrogen. This is called anti-androgens, which is called hirsutism or gynecomastia. The most is important is that is this drug cause gynecomastia, anti-androgen effect of this drug or hirsutism. There are other drugs are available which are selectively and not causing anti-androgen effect, but they are not available in the markets. Once the blood pressure is controlled with aldactone or along with AC inhibitors, plus the sometimes you use the calcium channel blocker also to control the blood pressure and to raise the potassium level. Thus, aldactone is good enough to correct the hypokalemia. So once the preparation of the patient is done, well controlled blood pressure and normal level of the serum potassium by using the medications, the answer is if the localizing lesion is lying in the right or left adrenal gland is a adenoma, the answer is you have to do the unilateral adrenalectomy, and after that you will find the blood pressure is controlled in majority of the patients with some supplement of AC inhibitors, and the potassium level tend to become normal. So this is the treatment for adenoma of the zona glomerulosa, which secretes large amount of aldosterone autonomously because it's not under the control of the renin-angiotensin mechanism. If this is a secondary hyperaldosteronism, you will find the aldosterone is raised, but the renin activity is also raised. So if the renin activity is suppressed and aldosterone is raised, it means this is a case of primary hyperaldosteronism. In secondary hyperaldosteronism, the aldosterone is elevated, but the renin activity is much more as compared to aldosterone level. So if both are raised, especially the renin activity is elevated, the diagnosis is secondary hyperaldosteronism. And the common causes of secondary hyperaldosteronism is the hepatic failure, liver failure, congestive cardiac failure, or renal failure, because the renin activity is raised and there is a intravascular volume is reduced, and that leads to renin-angiotensin mechanism gets activated, and that can raise the level of aldosterone. If you know physiology, that there are three mechanisms which control the aldosterone level. One is the angiotensin 2. Renin-angiotensin mechanism is one of the potent regulator of the aldosterone level. The second is the hyperkalemia, which also stimulates the aldosterone secretions, and to some extent, in a small number of the times you will find that ACTH to some extent also regulate the aldosterone, but the potent is the angiotensin 2 and the excess of potassium, and to some extent by the ACTH. In case of congenital or the bilateral adrenal hyperplasia, which is in 65% of the cases, the treatment is not surgical. The treatment is medical. You can use the aldosterone receptor antagonist, that's aldactone. It is also known as spironolactone, between 100 to 200 milligram, dose variable depending upon the severity of the disease. You use daily, plus the some other supplements for antihypertension like ACE inhibitors or calcium channel blockers. That you have to continue the treatment, medical treatment. If the potassium level is very low and effective to medical treatment, then answer is to may go and in a desperate situation of refractory hypokalemia, you can go ahead to do the bilateral adrenalectomy and followed by the long life cortisol in a divided doses, plus if the need arises you can also add up the fluorocortisone 0.1 milligram twice a week or thrice a week, and you also increase the sodium in the diet in the situations when one has to go and do the bilateral adrenalectomy for refractory cases of hypokalemia. The second pathology you see in the adrenal cortex is the zona fasciculata, and that principal hormone secreted by the zona fasciculata is cortisol. The cortisol is a glucocorticoid. Its action on the carbohydrate, fat, and the protein metabolism is glycogenolysis, gluconeogenesis, lipolysis, and also is negative nitrogen balance. It breaks down the proteins, and that amines they are used for gluconeogenesis to produce glucose. So this is a hyperglycemic agent when it is used in large doses, when it is in sex excess. Hypercortisolism, the patient who has got increased level of the cortisol, you label as Cushing syndrome. In fact, Cushing syndrome is inappropriate excretion or increased level of the cortisol in the blood. The most important cause of Cushing syndrome is exogenous steroids. A patient on delta cortical or because of the chronic bronchial asthma or autoimmune disease like SLE or rheumatoid arthritis, polyarthritis nodosa, so or as a chemotherapeutic agents in which the cortisol or dexamethasone is also used. So that is one of the leading cause of Cushing syndrome is the exogenous steroids, that is called iatrogenic Cushing syndrome. This is very much important. You must ask the history of steroids in a patient when you see Cushinite face like facial plethora, edema of the face, fish-like mouth, slit-like eyes, buffalo hump, truncal obesity, wasting of the muscle in the extremities, the thin slim extremities, bruises, ecchymosis, abdominal stria, and the patient usually very weak. The bones are weak, osteoporosis, osteopenia. Sometimes they develop pathological fracture also, hypertension, diabetes, and also some degree of hyperlipidemia also. The diagnosis of Cushing syndrome is written on the face of the patient, and the hypertension is also a feature of Cushing syndrome, and also the hyperglycemia diabetic. Diabetes is also common in these patients because of the gluconeogenesis and glycogenolysis by the increased level of the cortisol. The majority of the causes of this excess level of the cortisol, non-iatrogenic, 80% of the cases is ACTH dependent. In the 20% of the cases, the underlying cause is in the adrenal cortex, that is adenoma or a carcinoma. Once you see a patient of Cushing syndrome, you first think about the iatrogenic Cushing disease or syndrome, that is exogenous steroids. The first investigation you should do is, one is the plasma, cortisol, and the ACTH. In majority of patients you will find the ACTH is raised and the cortisol is also raised. That is diagnostic of Cushing disease, and 80% of the cases the underlying pathology lies in the anterior pituitary, that is a adenoma of the pituitary. If you find that in 24-hour urine the cortisol level is raised and the ACTH is depressed, then the underlying pathology is the Cushing syndrome or disease, which means that the adrenal cortex is to be blamed. So cortisol level, raised cortisol level with depressed ACTH, the pathology lies in the adrenal gland, that is mostly is adenoma and rarely the carcinoma. And if you find the cortisol level is raised but the ACTH level is also raised, that more in favor of Cushing disease. Majority of the patients, they have got a microadenoma in the anterior pituitary. The simplest way to rule out is that you give him a dexamethasone suppression test. If you give him a 1 milligram dexamethasone, say at 11 p.m. at night, and you check in the morning at 9 o'clock, again the level of the plasma cortisol, you will find that if it is suppressed more than 1.3 nanogram or 3 nanogram, it means it is basically a ACTH dependent Cushing syndrome. While if a dexamethasone suppression test is negative, the level of the cortisol is not goes down or doesn't go down, it remains elevated, the pathology lies in the adrenal gland. If the ACTH level is raised and the cortisol level is not suppressed, the answer is the source is ectopic ACTH, and the ectopic ACTH, the common one, is the carcinoma of the lung or cell carcinoma of the lung is the common pathology which can produce ACTH-like substance, cancer of the kidney. So ectopic ACTH can cause the raised level of the cortisol. Until unless you don't deal with the primary pathology, this disease will never under control. Provided you can able to detect the primary malignancy which produce ACTH-like substance, and the notorious one is the carcinoma of the lung, melanoma, hypernephroma. So these things you should keep in mind. The treatment of the once you have diagnosed a case of Cushing syndrome or Cushing disease, one and the same thing, increased level of cortisol. If it is ACTH dependent, majority of the cases the lesion lies in the anterior pituitary. The answer is you get a CT scan or MRI, which can able to pick up the microadenoma, which is more than 5 millimeter in size. The treatment of Cushing disease, which is ACTH dependent, and the primary pathology is microadenoma in the anterior pituitary. The treatment is transphenidal microadenidectomy. That is the treatment of choice done by neurosurgeons. Approach is transphenidal. And if the cause of the Cushing syndrome is the ectopic ACTH, then you should deal with the primary malignancy of the body. If it is a cancer of the lung, you have to treat for lung cancer for pneumonectomy, and if the underlying cause is the hypernephroma or melanomas, so they treat the primary pathology to control the Cushing disease. If the pathology lies in the adrenal gland, especially adrenal cortex, because that pathology lies in the zona fasciculata of the adrenal cortex, the answer is CT or MRI. Both are very sensitive and specific to pick up the adenoma or a big size lesion in the adrenal cortex. The treatment is unilateral adrenalectomy for the adenoma or say big size tumor which may turns out to be a carcinoma. So target lesion should be identified by MRI and CT scan, and you prepare the patient first. As I have already discussed, no endocrine surgery should be done without the preparation. You should control the disease first, and then you subject the patient to an operation so that you can able to handle or the metabolic crisis during and after the operation. So in order to reduce the incidence of metabolic crisis, you must prepare the patient prior to the surgery, and that is drugs used for control the blood pressure and to lower the level of the cortisol, and the drug which is used for to control the level of cortisol is the ketoconazole, and sometimes the people some use second line is the aminoglutamide, but usually in practice use ketoconazole to control the blood pressure by lowering the level of the cortisol. That is, in some cases it's very difficult to pick up a microadenoma of the pituitary. So the question is what to do. In old days, the cross-sectional imaging is not so common available. Nowadays you have got a 4D CT scan and MRI, which are very sensitive to pick up the lesion which is more than half a centimeter. But in old days, when it is not possible to detect the microadenoma in the pituitary, the answer was the target organs should be removed. And the target organs are both the adrenal gland, which undergo hyperplasia, and you do the bilateral adrenalectomy to control the symptoms of the patient, and then you put on the patient on the cortisol for the rest of life. And that is bilateral adrenalectomy in situations when the primary pathology is not possible to detect it, especially in the pituitary or somewhere else where there is an ectopic ACTH. The target organ is not possible to find out where is the lesion is. There is one common condition which was in old days is Nelson syndrome. The Nelson syndrome was 30% in old days when the imaging techniques are not available to detect the microadenoma of the pituitary. They do the target lesion to control it by doing the bilateral adrenalectomy, because that is a target for ACTH to undergo hyperplasia and produce large amount of cortisol by both the adrenal glands. So what to do? The target organ taken off, bilateral adrenalectomy. So what happens? The ACTH secreting tumor becomes enlarged in size. The patient complained of headache, vertigo, bilateral temporal hemianopia, and this lesion of the pituitary adenoma enlarged in size, and this can lead to even unilateral or bilateral blindness, and with severe degree of hypercortisolism, because this ACTH sometimes stimulate small amount of the adrenal tissue left over while doing the bilateral adrenalectomy or ectopic cortical tissue somewhere that undergo hyperplasia, and the patient will have to go to increased level of the cortisol, increased level of the ACTH, and ACTH when in excess amount produced by the pituitary tumor, it behaves like melanocyte MSH type. So there is also pigmentation is there, the high blood pressure is there, ACTH level is also raised, and patient has got bitemporal hemianopia, headache. So this is what is called Nelson syndrome. But nowadays, as you can pick up the microadenoma of the pituitary, so the cross-sectional imagings are available. They are very sensitive and specific. You can deal this microadenoma by transsphenoidal approach, that is called transsphenoidal microadenidectomy. So the incidence of Nelson syndrome nowadays only in 1 to 2% of the cases, when the microadenoma is too small to be picked up, and then later on as the time passes, this pituitary tumor enlarge in size, presenting as a headache, vertigo, bitemporal hemianopia, and sometimes you can lose the vision also with hyperpigmentation of the hands. This is typically in case of Nelson syndrome with increased level of the cortisol and increased level of the ACTH. The treatment of Nelson syndrome is to deal the pituitary adenoma, and that may be a transsphenoidal, which is sometimes difficult, or you can do the transfrontal approach, and if the residual tumor left over, you can do the irradiation by gamma knife or by external beam irradiation to ablate the pituitary tumor. So that is all about the Cushing syndrome and Cushing disease. Cushing syndrome, you can label as an elevated level of the cortisol, and the cause may be lies in the pituitary, ectopic is GTH, or it may be in the adrenal glands in the form of adenoma or carcinoma. The third pathology in Cushing, after the Cushing syndrome, you will see in the zona reticulosa. The zona reticulosa is the innermost zone of the adrenal cortex, and if its autonomous is produce excess amount of the androgens, that is dihydroepiandrosterone, and these androgens metabolites ultimately converted in by the peripheral tissue into testosterone, and rarely it produces the androgen. So the tumor arising from the zona reticulosa, there are two. One is the excess amount of androgen producing tumor, which produced in the male is a precocious puberty, and the female it causes the virilization. The virilizing tumor, they are more common, arising from the zona reticulosa, and this excess production of androgens in the female, they produce virilization, development of the distribution of the male hair distribution on the scalp. You can have got a beard, mustaches, and the muscular development is also there. The breast tissue is rudimentary, and masculine characters you will develop in the females. And there is also like neuromegaly and the muscular development, and there is also amenorrhea. So these characteristics virilizing tumor arising from the adrenal gland, especially the adrenal cortex, from the zona reticulosa. Sometimes, very rarely, you have got a feminizing tumor, but usually they are the virilizing or androgenic tumor of the zona reticulosa. So they are typically the precocious puberty in the males, and then the female is the virilization of virilizing tumors. You get the level of the dihydroepiandrosterone and dihydroepiandrosterone sulfate. These are two androgenic hormones produced by the zona reticulosa in excess amount, which are ultimately converted by the tissues in testosterone. You can also check the level of the testosterone. So these androgenic hormones, they are elevated. The diagnosis is confirmed localization studies, CT scan or MRI. The treatment, majority of these tumors, they are malignant, and some they are also benign. The malignant tumor, they have got a combination of not only the virilizations, excess of the androgen, but also the increased level of the cortisol. So if you have got the virilization plus increased production of the cortisol, gives rise to the Cushinite phase, they are likely to have a carcinoma of the adrenal gland. So virilizing tumor is one of the pathologies you can find in the adrenal cortex from the zone of reticulosa. Usually the virilizing tumor in the female, they arise from the carcinoma of the ovary, and if the ovaries are normal, then the second target organ will be the adrenal cortex. So the underlying pathology is dealt by performing a unilateral adrenalectomy, having the localized lesion revealed on CT or MRI. That is about the disease of the adrenal cortex. One is the Cone syndrome, second is the Cushing syndrome, and third one is the virilizing tumors of the adrenal cortex arising from the zona reticulosa. That finished about the hormone producing lesion of the adrenal cortex. Now we are going to discuss a very aggressive tumor of the adrenal gland is called adrenal cortical carcinoma. The carcinoma of the adrenal gland is a very, very, very aggressive tumor. By the time it is diagnosed, 50% of the patients have got distant metastasis. The prognosis of this adrenal cortical carcinoma is very poor. The average lifespan is 1 to 2 years because the disease is diagnosed as stage 3 or 4, and biologically the tumor is very aggressive. %60 of the adrenal cortical carcinoma, they are hormone producing tumor, and the principal hormone produced by this adrenal cortical carcinoma is cortisol, one, and second is the sex production of the androgens. This has got a Cushinite phase plus the virilization in the female. In the male, precocious puberty; in the female, virilizing tumor, and plus the excess level of the cortisol in the blood. If you look at a patient who has got a virilization, the diagnosis is carcinoma of the adrenal cortex, especially in adults or in children. The investigations you will do for it, one is the CT scan or MRI. Usually the tumor, they are more than 10 centimeter, large size tumor, and second you will find there is also a metastasis in the liver or somewhere else like lung. The treatment of the adrenal cortical carcinoma is surgery, and the operation you do for it is radical nephrectomy, that is radical nephroadrenalectomy. It removes the adrenal gland along with the kidney because it has invaded the kidney, and plus also the lymph nodes, subdiaphragmatic and the renal lymph nodes, and if some other organ is involved, you have to take in monoblock resection. Majority of the patients, they develop local recurrence because the resection sometimes is complete, but in majority of patients you do the marginal resections, and the tumor recurrence is very common in these conditions. The treatment is radical resection if it is permissible, that is nephroadrenalectomy, plus the en bloc resection of the adjacent tissues, including the lymph nodes. If it is not possible, you do the marginal resection sometime you have to do the debulking procedure, that is called as the cytoreduction, followed by use of the adrenal agents like mitotane. This is a drug which is used very extensively in the past. This mitotane not only destroys the tumor cells but also destroys the normal adrenal tissues. It is a very toxic drug. Nowadays, they are not using so frequently because of the hepatotoxic effect and the toxicity on the different organs. They use in combination with other chemotherapeutic agents. And when you use this mitotane, you have to use the corticosteroids because the other adrenal gland also undergo atrophy. The tissue is also destroyed. On the contralateral side, the patient has to live on cortisol. Prognosis is very poor, very aggressive tumor, diagnosed at a later stage, and the poor prognosis. There is no 5-year survival rate in our country because majority of the patients will come very late as stage 3 or stage 4 disease. Patient die within 1 or 2 years after the resection despite receiving the adjuvant chemotherapy or adrenal agent like mitotane. That is about the carcinoma of the adrenal gland. Now we will discuss another terminology in this adrenal gland is the incidentaloma. Incidentaloma is an incidental mass picked up within the adrenal gland by CT, MRI or PET scan. Cross imaging radiological techniques done for other disease. That is called incidentaloma. First, when you diagnose a case of incidentaloma, which is a silent picked up by the radiological imaging done for an investigation of the done for the other disease investigation, is called incidentaloma. Incidental mass in the adrenal gland is called incidentaloma, which was silent. When you pick up incidentaloma, there are 3 things for a surgeon is very important. Is it really the mass within the adrenal gland or in the adjacent tissue, like sympathetic nerve, like ganglioneuroma, or like it's arising from the liver? So it is very important. You should be absolutely certain that this incidentaloma actually arising from the adrenal gland. The second important thing for a surgeon is it is a hypersecretory or functional mass or it is a non-functional mass. When I say functional or hypersecretory mass, it means you have to check first. The most important lesion to rule out is pheochromocytoma. 40 to 50% of the pheochromocytoma are diagnosed as incidentaloma. So it is very important that you must rule out pheochromocytoma by doing the plasma metanephrine or norepinephrine or urinary metanephrines or catecholamines, or but plasma metanephrine is very easy to do quickly, and that can clinch the diagnosis that this silent incidentaloma is a functional one, hypersecretory, and this is a pheochromocytoma. If, or second thing you should also do is the serum aldosterone level. If it is raised, you also check the renin activities. You may have got a hyperaldosteronism primary, which is not so common, 0.1%, and 6% of cases you may have got a non-iatrogenic Cushing syndrome or subclinical Cushing disease. You only find the raised level of the cortisol, or you can check the urinary 24-hour urine hydrocorticosteroid. That rule out the subclinical Cushing. If it is there, you should know before it. So, pheochromocytoma, subclinical Cushing, or rarely primary hyperaldosteronism, if they are picked up by doing this biochemical test in the blood, I think the hypersensitivity or functional adenoma, no matter whatever the size is, must be excised. And that is unilateral adrenalectomy, no matter whatever the size. But if it's a secretory or hyperfunctional lesion, that should be dealt according to their own merit after the preparation. Regarding the non-functional silent lesion, the commonest one in 80% of the cases is cortical adenoma, which is a benign, non-functional. That is the commonest lesion. The second commonest benign lesion, in addition to cortical adenoma, is the myolipoma. This is also a benign tumor arising from the adrenal gland. It consists of fat and the myeloid tissue components. This myolipoma can be large in size, maybe up to 10 to 12 centimeter. But this myelolipoma is the exception, that size doesn't matter. If it is bigger in size, you should not operate if the CT or MI picture is classical, homogeneous and suggestive of myelolipoma. The other benign lesions, you have a adrenal cyst, hemorrhage, and these lesions, they should be follow up. No need to operate on these patients having adrenal hemorrhage or endothelial cyst. Follow up is only necessary. The only problem with the non-functional incidentalloma is the size of the tumor. If the size of the lesion is more than 6 centimeter, the answer is you have to excise the lesion. That is unilateral adrenalectomy. If the lesion is between 4 to 6 centimeter, one should also consider the imaging. What are the feature in it? So 4 centimeter is the cut point for the size. If the lesion is 4 or more than 4 centimeter, you should excise it. That is unilateral adrenalectomy, because there is also a chance of carcinoma as the size exceeds 6 or more than 6 centimeter. So nowadays the 4 centimeter is cut-off point regarding the size. If the size of the lesion or incidentalloma is less than 4 centimeter, say 3 centimeter or 2.5 centimeter, one should follow up with imaging, and imaging should be every 6 months. If the size increases more than 50%, then answer is you have to have an operation. So rapidly enlarging size in the lesion which is on follow-up for CT or MRI suddenly become increase in size, the indication is operation. So the fear for the size is the fear for carcinoma. Bigger size, higher chances of carcinoma. Smaller size, lesser chances of the carcinoma. But the cutoff point is 4 centimeter. Above it or 4, take it out. Below 4, follow it up with CT or MRI every 4 months, and then after every year, initial first year every 6 months, and next one every 1 year. If the size remains stable, there's no need to take it out. That is all about the incidentaloma. There's sometimes a full question comes on write note on incidentaloma. That finished the disease of the adrenal cortex.